Good day. My name is Bill Detmer, CEO of Unbound Medicine, and I'm delighted that you could join us today for a COVID-19 update. We are very fortunate to have our friend and collaborator, Dr. Paul Auwaerter, who, as you know, is a professor of medicine at Johns Hopkins School of Medicine and the director of the Division of Infectious Diseases there. And Paul will be, as he has for us many times during the pandemic, give us an update on what's new, what's happening, what's coming. Today's format will be question and answer. And we're very grateful to those of you who have written in your questions so far, and we will try to get to as many of them as possible. This webinar is being recorded, and a link will be shared with you by email. It will be in the Johns Hopkins Guides website and posted on YouTube. So let's get started. Paul, it's hard to believe, but it's been just about 2 years since SARS-CoV-2, or what was, I guess, called nCoV-19, came to our shores. And boy, have we gotten the schooling in kind of biology, science, and medicine in that time. Who would have thought that 2 months ago we didn't even know there was this variant called Omicron, and now it's everywhere in the globe. So that would be a great place to start. Tell us what's new, particularly with Omicron.
Yeah, Bill, thanks so much. Delighted to be here. As always, I'm always hoping this is the last webinar in this series, but this virus has confounded many. And as much as the virus has changed, we've had to change our practices. And the fact that so many regulatory agencies, pharmaceutical companies, and so on have really worked at tremendous speed in response is really a testament to how far and how fast science has come with regards to dealing with this coronavirus. I'm going to go ahead and just share my screen here. So what I'd like to do today is just briefly go over 3 areas. First is just briefly mention the Omicron variant. The second is touch upon testing, which remains important. And then, of course, spend most of the time on treatment, especially as there are new agents available, hopefully in increasing supply. Anyone that's looked at the Omicron variant in almost every country where there's been intensive testing has been a rocket ship of a rise, and that was indeed the case just after the Thanksgiving holiday here. And just as rapidly as case numbers have climbed, they've decreased, but importantly, this is no doubt a vast underestimate because antigen testing is not incorporated into any reporting to state health departments or the Centers for Disease Control. The point, though, to make, and it's been said by many scientists, but also you've seen it in the media, is that Omicron seems to be less virulent, as it were, than a Delta or earlier variants. And this might be witnessed, especially if you look at the hospitalizations where the numbers have never been higher, but the number of cases, no doubt, are far higher than they had been with earlier surges. And of course, death is a lagging indicator, but that is also the hope that per number of cases, the mortality rate would be less. And this, of course, is not just the Omicron variant, but may also be due to immunization status and healthcare. Just as the number of cases have risen, so has the fact that Omicron has rapidly displaced Delta variant seen in orange when looked at coalescing national sequence data that is forwarded to the Centers for Disease Control. As of mid-January of 2022, comprises 99% of virus. And there may be some lingering Delta and even some other variants out there, but has clearly established itself because it appears to be at least twofold more contagious, more transmissible than the Delta variant. Now, how we're approaching clinical care remains rooted for the most part, in data gathered in the first year or so of the pandemic, where there was always a steep age gradient, as well as acknowledgement that comorbidities added to age, at least when people were largely unimmunized. So this probably has changed to some degree, both because of the Omicron variant and also immunization. But as we think about how we're looking at prescribing medications and also distributing them, this kind of comorbidity and age gradient continues to be at play. You might ask, so what do we know about Omicron and why is it less virulent? And we only have some very early and preliminary indications, but data out of the Gladstone Institute, where they have a pretty good set of mouse models that seem to replicate closely to human disease, has found that the viral load of Omicron in the lung is 3 logs lower than we're seeing if you infect mice with the Delta or Wuhan ancestral strains. Also, there seems to be less inflammation, and unlike what happens with Delta or Alpha, where the amount of T cells seem to be depleted rather rapidly in severe cases, that does not seem to be the case. So that's all good news. On the flip side, looking at some serological responses, Omicron clearly does not respond as well to either prior infection and antibodies generated, or those that have been generated by vaccines, although the mRNA vaccines clearly still perform the best. The neutralizing antibodies are definitely Omicron specific in people that are infected with Omicron, but interestingly have limited cross-reactivity to Delta and Wuhan, probably because the spike protein is so different. Interestingly, if people have had prior coronavirus infection with either Delta or Alpha and so on, Omicron does provide a cross boost, so it seems to boost some of that immunological memory. So we have a complex picture, but we're beginning to get some insights as to what might be happening. Of course, everyone is hoping that widespread Omicron immunity will somehow staunch further disease worldwide and emergence of variants, but I think that might be premature, even though people as like Tony Fauci are cautiously optimistic, and of course, only time will tell. Thinking about testing, I've had a number of stories of my own patients and family members who have had a sore throat, a runny nose. They wanted to visit for the holidays. They do an antigen test, it's negative. They do another antigen test, it's negative. Then they do a molecular test and it's positive. And I think this has no doubt created opportunities for Omicron spread, but also people are questioning the reliability. And it's not absolutely clear that the antigen detection itself is at fault. Studies that at least have looked at one of the more popular tests, the Binax Now kit, that is part of the federal distribution effort that's now underway. When it's been studied, sensitivity ranges from 50 to 90%. And again, this has been authorized for use in the first week of illness. If you do have symptoms and it's positive, you can really take that home. It's specific, but it is not that sensitive. Now, we only have some early-ish data. I'm sure more will soon be forthcoming, but I thought this one preprint that is out was an early look at Omicron and comparing that to PCR positive swabs. And not unsurprisingly, if you had very high numbers of viral copies on the swab, the antigen test works well compared to PCR with either the Delta or Omicron variant. There was more variable detection, especially as you got down to levels 20,000 and below. And of course, RT-PCRs on hospital platforms might detect as little as 2 log of viral copies. So the features that I just mentioned, at least where viral load seems to be lower, especially perhaps in immunized people in the nose, is another facet that's making detection difficult. And therefore, it's always a good practice if you're around someone who is at risk for severe disease, an organ transplant patient or so on. You may want to stick with molecular tests as best as possible to be more certain of your status if you're ill or need screening.
Well, thanks for that, Paul. That was fascinating update on a rapidly changing situation. What's been particularly interesting with Omicron is, from what I understand, and you'll tell us about, how different the profile is of responsiveness to antivirals. And that's led to a scramble of evaluations, studies, and recommendations. And those recommendations have been changing fairly rapidly. The NIH guideline panel has revised their recommendations several times just in the last month. So it would be great if you could enlighten us on what the choices are and what the current recommendations are for treating patients with COVID who, before hospitalization or as an outpatient, who are at high risk.
I agree with you. Now, as we pivot to therapeutics, I'm not going to spend any time on the right-hand side of the slide because the algorithms and treatment suggestions for people admitted for severe COVID-19 has not changed very much over the past months. It's really on the left-hand side where much has happened in the last 2 months or so. And importantly, because of the Omicron variant, the double red asterisk drugs, the monoclonals that we had become so reliant on for our high-risk patients, it does not have activity against the Omicron variant. So these effectively are not being used. They haven't been withdrawn, but the supplies are potentially still shipped if needed, but should not really be administered depending on the percent that we see in the 99% range with the Omicron variant. So we'll focus more on non-hospitalized patients and some of the treatments and preventative measures that may be important and you will be incorporated in your patient care. So the oral antivirals are two. The one that's generated the most excitement is Nirmtrelvir. This is a coronavirus-specific protease inhibitor. It was actually developed from an intravenous formulation. And if you look at the graphic, it works similar to HIV protease inhibitors in that it inhibits the proteolytic cleavage of a polyprotein that would then go on to make critical non-structural proteins that the virus requires for production of genomic RNA and assembly. So by poisoning the protease, that very much limits the virus's ability to replicate itself. What's truly remarkable here is the idea of an oral protease inhibitor to a phase 1 trial was accomplished in under 12 months. So this means animal safety data and efficacy data all was carried out rather rapidly so that the first clinical trial of phase 1 could be launched. The drug itself hangs around for about 6 hours, half-life with minimal metabolism, and it's predominantly renally excreted. And the trial, which has not been published but merely presented to the FDA, is the EPIC trial, a phase 2/3 trial of over 2,000 patients. Only modified intention to treat data was presented to the FDA. And it's important that because this drug was rushed, this is not co-formulated, this is co-packaged. You get Nirmtrelvir tablets, and it's complex with Ritonavir in an effort to slow the metabolism of the coronavirus protease inhibitor to sufficient levels. So the drug was given for 5 days to people that had ambulatory disease, over 18 with at least one risk factor. And all these trials that we'll be discussing today were in unimmunized people. And the primary composite endpoint was 28-day hospitalization or death. There was a remarkable decrease from 6.3% to 0.8%. So that effectively meant that for people treated within 5 days onset of symptoms, there was an 88% reduction. Deaths were 12 in the placebo, none in Paxlovid. Drug was generally well tolerated. Now, this drug is a home run if you look at efficacy for viral disease. If you could diagnose your patient and get it on board fast enough. The trouble is on the lower part of this slide. Because of the Ritonavir especially, there are many contraindications and drug interactions, often for patients with comorbidities who are on drugs that might preclude prescription of this medicine. It does need to be renally dosed, which we'll talk about. And then there isn't any genotoxicity per se, and some experts have said it might be okay to use in pregnant women since we have some experience with protease inhibitors that are used extensively in HIV-infected pregnant women. So Paxlovid was granted an EUA by the FDA in December of 2021. And the age, interestingly, was lowered to 12, even though it wasn't analyzed in the adolescent population, likely because of perceived excellent safety profile. Anyone who gets this drug should have at least one risk factor for progressive disease. Again, using it within 5 days of symptom onset, predominantly because antivirals work best the earlier they're administered. And the drug is definitely not authorized for pre-exposure prophylaxis, post-exposure prophylaxis, or if you're hospitalized. Now, the dosing, again, mentioned, this is co-packaged, not co-formulated. So you essentially take 3 pills twice a day for 5 days. The drug interactions is something that truly bedevils. And of course, anyone that takes care of HIV patients, especially from earlier eras, is quite familiar with Ritonavir. Nirmtrelvir has some impact, but is not really clinically significant in terms of inhibiting or altering metabolism. However, as a reminder for those that might be less familiar with Ritonavir, this drug binds to CYP3A4, and when it does so, it's an irreversible process. So basically, there's no competition. You cannot overcome the poisoning that this essentially suicide inhibitor has. So you really have to wait for enzyme turnover and lack of drug administration. So this is one of the reasons why it is such a potent inhibitor of the enzyme and can cause dramatic drug elevations. So the EUA itself has these contraindications listed. On the left-hand side are elevated concentrations. On the right-hand side might be drugs that would affect Ritonavir itself and therefore reduce Nirmtrelvir concentrations. Now, this is only the contraindication list. This is not the drug interaction list, and that's of course too comprehensive and always worth checking with your pharmacist or drug interaction database before prescribing for all of your drugs your patient may be on. The last is rather curious, and I thought I'd show you the blister pack as this is co-formulated on the left. However, if you have reduced renal function because the drug's excreted, pharmacists are supposed to push out some of the pills to reflect the reduced doses and then slap on a stick-on label over the package about the preprint dosing changes compared to how the packet is made. So clearly this is because of the rush to try to get this drug, which is really only being made, to my understanding, one plant in Groton, Connecticut, as much as possible, but supply is really insufficient to meet demands, and in most states, it's very hard to find this drug. Now, it is not, there are no recommendations if people have severe renal failure with GFR less than 30. And that's mainly because there's just been no dosing determined yet in this group. So at the moment, probably should not be used in that drug class. Now, Paxlovid generated a lot of excitement. I think when I deal with patients, I often have to first take that quick pass, looking at drugs to see if they're even eligible. And especially for transplant patients that could be on cyclosporin, sirolimus, tacrolimus, those are relative contraindications, and we've already seen toxicities with a marked elevation in those drugs, even with just 5 days of the Paxlovid and even holding their tacrolimus, for example. So seen CNS toxicities. So pivoting to Molnupirpiravir, this is an antiviral that probably a little more familiar with just by the sheer number of drugs. Similar to ribavirin, this is a nucleoside analog. And it's a prodrug that's metabolized to molnupiravir triphosphate that essentially then substitutes itself mainly for cytidine, less likely guanosine, and you get unintended or intentional substitutions that ends up being a lethal mutagenesis for the virus. There's minimal metabolism, very little is excreted into the urine. So unlike the protease inhibitor, this drug is actually very easy to use. The efficacy data for the Move Out trial, which was published in December in the New England Journal, was a little over 1,400 patients who, again, were unimmunized, had at least one risk factor. But initially, the interim preliminary analysis suggested a 50% reduction in hospitalization or death in this ambulatory population. But the larger and a more complete data set showed that risk reduction fell to 30%, as you can see in the graphic. The drug was generally well tolerated. There's been mixed studies on genotoxicity, which we'll talk about in a moment. But importantly, there's no renal dosing adjustments, no contraindications, no drug interactions that are really known. So this drug in and of itself has a cleaner side effect profile compared to the protease inhibitor. The drug itself comes as 200 milligram capsules. You take 4 at a time, twice a day. Very similar indications to the protease inhibitor drug. Buried somewhat in the FDA approval and letter is this language regarding patients that might be interested in childbearing or have that potential due to genotoxicity concerns in host DNA. Women are to use contraceptive measures or abstinence for at least 4 days after stopping the drug. Interestingly, men who, of course, make sperm that will hang around a bit longer are counseled to do the same, but for 3 months. So I think this is not widely known. And then lastly, I'll touch on Remdesivir, which we usually think of for inpatients. However, as many of the agents we just spoke about are in limited supply, but Remdesivir is not. Trial data from the Pine Tree study was discussed in the fall at a major ID meeting, published recently in the New England Journal. This trial was actually halted early because monoclonals became available, and compared to the 3-day dosing scheme here used for Remdesivir, predominantly was thought to just be too logistically troublesome. But as Omicron and emerged, it became obvious that our lack of other monoclonals, such as the Regeneron product and the Eli Lilly product, meant that we really sorely needed alternatives. This study had a little over 500 patients. The drug profile itself looked very reasonable, with no major safety concerns in this ambulatory population that were not ill or hospitalized. Yet there was an 87% reduction, sort of in keeping with what we see with monoclonal antibodies or Paxlovid, in terms of preventing hospitalization or death in the first month, and also a reduction in the need for medical visits. Interestingly, virologic data looking at nasal swabs didn't see any viral impact. So it may be elsewhere in the body, in the lung or in organs, but we've had a hard time showing this drug impacts viral carriage in the nose. If this drug is used and for 3 days, you can avoid hospitalizations, but the logistics of doing this in the outpatient arena, at least for our health system, was very difficult because we didn't have the space or the staffing for serial 3-day infusions for people. Done a few through home care, for example, but this is something that we're using more in the hospital for people that might come in with incidental COVID and other issues rather than severe disease. Lastly, Sotrovimab, just to highlight, is the monoclonal antibody of the day. It's the only one that has activity against Omicron, mainly because it was developed against the original SARS-CoV-1, binds to a highly coronavirus conserved portion of the receptor binding domain. Study here, combined data. It was the New England Journal had a more limited population compared to what the FDA used for its data calculations, but basically very effective with the same kind of metric for outpatients in terms of avoiding hospitalization or death, with an 87% reduction, or perhaps 79% if you accumulate all phase 1, 2, and 3 data. Very well tolerated with a really equivalent infusion reaction rates, although there are occasional episodes of anaphylaxis, which does require people to hang around for about an hour for observation. So if you look at all these, and again, this is not by any means a fair comparison. These trials were not head-to-head, but as we look at the available therapies for people that might be at high risk but are not hospitalized, Paxlovid does well. There is also a possible mortality advantage. Also true for Molnupirpiravir, although its effect and risk difference is markedly less. Remdesivir is another option, and of course, Sotrovimab. I haven't shown data from a preprint that's currently under review, but convalescent plasma has sort of fallen to the wayside over recent months, but was revised with a new EUA recently only for immunosuppressed patients. And this also has effect in terms of preventing hospitalization and death, as you can see here. And the number needed to treat column, again, is just a very rough gauge to help understand really how much impact these drugs might have. It's not as though everyone goes on to develop severe illness. So this is complicated graphically, but this was released by the US government, which I think sort of tells you what the thinking is in terms of how to use these drugs as outpatients. This is very much in keeping with the NIH tiering of the outpatient therapy. And Paxlovid is on top, mainly because it's oral and effective, then Sotrovimab, and then Remdesivir. And only if all three of those are not appropriate for your patient do you consider Molnupirpiravir. And of course, if you're looking for drugs right now, Molnupirpiravir is the one that's available largely, whereas others could be more resource challenged or just have difficulty with administrations. So this also is in keeping with many health systems that may have tried to tier the release or appropriateness of using medications in certain populations to target people at highest risk.
So Paul, that's fascinating material, and the speed of change of these recommendations has been, lightning speed. The NIH guidelines panel has revised their recommendations here several times in just the last month. As a general internist, I wonder whether, the complexity of this algorithm and the speed at which it needs to be determined and the resources required for the drug to be available and for the centers to be able to cope with IV infusion, if that is recommended, is quite complex. How do you, as an ID specialist, think about that and advise generalists how to handle this particular cohort of patients?
Yeah, Bill, this has been very challenging, and there have been a number of stories in the press of people trying to procure drugs and running into all sorts of barriers. The barriers could be, is the drug even available? Does office staff who answer phones know, what's their level of understanding, rather than relating information to doctors? Doctors may not yet be up to date on all this information, given all the demands. So it's been very challenging, and I think that some institutions have tried to highlight and direct therapies to those at highest risk, and I think there's always the challenge that when you do that, you may have missed opportunities because you're trying to I won't say reserve drug, but at least target drug to those populations. And look at this algorithm here. I mean, there's a lot of things going on here. And it makes sense to someone like myself, because I talk about this, I've been reading the papers. This kind of complicated algorithm makes sense. And I think for anyone that understands all the studies, is sort of lives and breathes COVID, it makes some sense. But even amongst our people that take care of transplant populations and so on, many challenges, and the drug interaction issue I cannot overemphasize, because many people that might be on contraindicated drugs are calling their family doctors, their internists that may not be as familiar. The pharmacists may not yet be as familiar. It's not actually in their databases yet, and it really requires some caution here. So I don't have an easy answer for that, other than saying hopefully educational programs like this, and asking questions, and for clinicians to become familiar, I think really depends on some case scenarios, which we could work through briefly, just like what would you do? And for example, with the renal transplant patient, I would look very hard for Sotrovimab if they're on tacrolimus, for example. And if that weren't available, Remdesivir is not an option, then we're really talking Molnupirpiravir. So if we can't get the monoclonal antibody is relatively easy. People were getting an understanding of that, how to refer people. So that took months just for the monoclonals to have some familiarity. Now you add two other oral drugs, each of which has some issues with it, perhaps. It's definitely challenging.
Mm-hmm. Well, it also, sort of commentary on our healthcare system. We don't really have a system for, a priori classifying people's risk, so that we, have some sense and resource planning where it should go and the systems for getting it there. So everybody's kind of on their own. And I suppose for specialists in areas like renal, where you have transplant patients, you can, that in areas like that, it would seem more easier to come up with guidelines for that particular subgroup. But as a generalist who may have patients with many comorbidities of many types, it seems very complex. So we do appreciate you helping us through this, and this algorithm might be something we could add to the Hopkins guides in some way as a way to help people traverse this.
Yeah, I think that's absolutely true, because we list all the drugs, but how you might actually handle a given patient, does it would be useful to walk through this kind of algorithm if you're not as familiar. So the last topic is pre-exposure prophylaxis, and this is new. Of course, we've had PrEP for HIV for some time. So this is PrEP for COVID, or I should say SARS-CoV-2 infection. And it's a combination monoclonal antibody, tixagevimab, silagevimab, that has had its FC portion modified such that it's very long-lived, up to 6 months. And this is given by 2 intramuscular injections, and the PROVENT trial was what was presented to the FDA. And it was a large trial, but as you can see, the endpoint was just any SARS-CoV-2 positive testing over 6 months. And this particular trial had, as you can see, only 8 in the treatment arm, 17 in the placebo arm, a 77% reduction. Essentially, this means the number needed to treat to avoid one infection is 125. Importantly, this was done pre-Omicron. The drug itself seems safe, but there are some caveats. The drug itself is only approved for immunosuppressed patients or patients who cannot take the vaccine. The preliminary data only had 83 days of follow-up on average for most patients. Some patients were immunized, and we don't know how well this works with Omicron. And there's this nifty web page that the NIH set up that looks at vaccine responses, also monoclonal antibodies, and you can toggle all sorts of variants on top. I've toggled the Omicron variant, and if you look down the antibody table, you can see Evusheld, at least in vitro studies, have suggested anywhere from a 10 to maybe 100 or more fold reduction in activity with Omicron. But if you look at the Regeneron product or bamlanivimab, etesivimab, you can see it's way over towards that 3 log decreased activity. So Sotrovimab retains activity. There is some reduction in Evusheld. And I think it's also important that Evusheld, because it's given by intramuscular injection, really offers no protection for the first 2 weeks until the antibodies are distributed through tissues. So you may have heard of some breakthrough infections, but really if they're occurring after the first 2 weeks of infection, that really will be the litmus test on whether Evusheld works as well. And it probably won't work as well as this preliminary data that was reported in order to garner the FDA EUA. So certainly time will tell of its usefulness and whether it may offer some protection if an additional variant pops up down the road. So I hope that was helpful and really appreciate everyone listening. And I know, Bill, we have some questions.
Yes, Paul. Again, thank you for that awesome update. How much we can still learn at this stage is incredible. One of the questions that we get from folks in various flavors is asking you a question that you're not a prognosticator or a fortune teller. And your specialty is infectious disease, not necessarily epidemiology, but I know that you know it much better than most of us. And so given where we are, we're here at the end of January 2022, and the Omicron variant is peaking in parts of the country in terms of cases, and hospitalizations are starting to come down. And we're also seeing, we haven't seen the same death rate as for previous variants, at least in its numbers based on the number of infected individuals. And given how fast this has come, what do you see as a scenario here in the next few months, and what things aren't we thinking about that could kind of spoil our hope that this might be the end of at least this version of the coronavirus epidemic?
Well, I think the number of people that land in the hospital, so hospitalizations and deaths, really are the metrics that I think remain most concerning. And clearly, immunization plus boosting seems to still have a significant impact there. So trying to get people immunized and boosted, even if they've experienced Omicron, I think will be important for some of the reasons I had mentioned, where Omicron antibodies don't seem to be quite as neutralizing their ability for Delta and Alpha. So you might see a scenario where some of a new variant or some of the older variants sort of reemerge in certain populations that may have had Omicron. I think might be a scenario that, if people are not immunized, would be concerning. Now, whether Omicron offers protection against hospitalization and death with coronavirus is really what I think remains to be seen, and also the durability of infection. Clearly, compared to common cold viruses, Bill, where you have about 1 year of protective immunity, it looks like SARS-CoV-2 natural infection generates somewhat longer lasting immunity in relatively healthy people. But for how long and how durable and keeping people out of the hospital is really key there. So I think there's some reasons for hopefulness, but again, I think we've been served many surprises along the pathway here. And there are some aspects that are a little concerning about Omicron, especially in people that are unimmunized, that I think there's this sense that natural infection's better and so on and so forth, but Omicron plus vaccine is probably still the best we can do, and really should be encouraged.
Mm-hmm. One of the interesting things about Omicron is where it is most impactful on the respiratory tract. At least from the things that I've read, it seems to infect more of the upper airway and less of the lower airway, and therefore may not be entering the bloodstream and having some of its inflammatory effects that way. From what you know about coronaviruses, which do have cold type viruses in the family, is that something to be expected, or was that a surprise?
Well, I think Omicron is behaving a little more, behaving somewhat similar to the common cold coronaviruses, the 4 that pre-existed the pandemic. So if this is the evolution, that's sort of the hopeful aspect. It's clearly more virulent and more contagious than those 4. So there's certain attributes to it. But the question, again, always on everyone's mind is there going to be a variant of high consequence? That's the designation WHO uses for a coronavirus that essentially escapes immune protection. And Omicron has not met that as a variant because there still is some immune protection, but if there's enough changes in the spike protein, then that becomes something that's much more serious. So that's the grave concern out there. I think there's still, from an epidemiological standpoint, great rationale to continue to get the existing vaccines in as many people as possible, including globally. And whether an Omicron specific vaccine or booster is required, I think it remains unclear. I'm sure some people might feel better having that additionally, but already some data suggests from Israel that a so-called fourth dose, whether you call it a booster or a 4th dose, didn't offer that much extra protection in terms of infection. That's something Israel tried to do early on as the Omicron numbers headed north.
Yes, and that relates to a question that we've gotten in many flavors, and that really has to do with thinking about COVID or coronaviruses of this type and the long haul, and with what we know about influenza and other viruses that have not only seasonal patterns, but also have kind of drift and shift patterns, so that what will that mean for kind of annual protection for a population? What of what we've learned from giving other vaccines do you think will apply to thinking about what we do for this virus?
Yeah, I think that's a very fair point. Remember, at least the coronavirus is not a segmented genome like influenza, so there's not so much the recombination events. So what was very surprising with Omicron was if the genetic phylogeny specialists have said that this actually came from a much earlier virus, and that it may have been incubating in an immunosuppressed person for a while. So it's not a natural outgrowth of the Delta variant. So I think we could be equally surprised coming in the coming months. It's just, again, one of those unpredictable features. But the immunity that either natural infection or the vaccine engenders, not just B cell, but T cell, I think is the aspects where I think it remains a very open question if relatively healthy people need additional vaccines moving ahead and at what frequency. I think for people that are immunosuppressed, they're already looking at dose number 4 fairly routinely after a 3-dose series and so on. And it's very clear people that don't respond well to the vaccine do benefit, a subset of them do benefit from getting additional doses. So I think we'll refine these recommendations as time goes on. The Omicron specific vaccine question is going to be out there. This came up with Beta, if you remember. Beta was a South Africa, first described in South Africa. There was concern about immune escape there as well. So both Pfizer and Moderna started a clinical trial with a beta spike protein, but of course those have been shelved now.
So I'm going to finish up with a question that comes up again in lots of different ways, and one that I have myself. And this is really on a totally different plane, I suppose, than what we've talked about. It's really about the human impact of coronavirus, not just on our population, but on our healthcare system and our healthcare workers. I guess the one thing that I would like to say as a non-practicing clinician, but being very involved in getting information out about it, just how amazed I am at what the resilience and the compassion and perseverance of 2 years of really gut-wrenching change continuously, overwork and exposure to all sorts of new experiences that have not been easy to contend with. And so I'm just wondering what it's been like for you as somebody who, runs a department in perhaps the most prestigious institution in this country, and also, taking care of patients and also trying to sustain the effort over a 2-year period, which is, an eternity, really. If you think about a marathon, that's a very long marathon. And I'm just wondering, anything you'd like to say about the experience, both your own and of your colleagues and the system in which you work, about what this has been like.
Well, Bill, I have to say, having been in the middle of a storm for so long, I continue to be amazed at really how resilient people are. despite very heavy demands, personal costs, both at home, at work, and then adapting to new environments, having floors entirely on bio mode in the hospital, wearing masks all the time, patients that are just as upset and challenged in terms of trying to deal with new environments. I think you see a lot transpiring sociologically as well, with just frustration levels, whether you're driving or unfortunately with crime and other aspects. This is no doubt a huge and major disruption. I am just amazed at the number of people that have continued to stay as fully and maximally engaged as possible to try to do best by patients, nurses, staff, clinicians. But I do also see people that are just, coming to the end of what they feel they can really handle. And you've seen, of course, many places in not just healthcare, but elsewhere in the workforce, where people are reassessing their lives. I think there's always good that comes out of terrible aspects, such as this pandemic, and the good might be, people who have had their lives affected by this, sort of doing some reassessment, hopefully something more meaningful. Younger generations, no doubt, even if they weren't involved in actual care, will look to this as something that may inspire them to hopefully enter the healthcare field. That's my hope, actually. We saw that with the HIV epidemic. It inspired a lot of people to enter that field. Infectious disease, take care of patients that really had no available treatments, but yet people entered the field. And I'm hoping we'll have much the same, whether it's nursing, whether it's pharmacy, whether it's healthcare practitioners.
Well, thanks for that, and thank you, you and your department and your university and all your colleagues who have been on the front lines for so long. And I hope that this confluence of biology, science, and medicine will cut us a break pretty soon here. Regardless, as you say, we'll be stronger and better for it. And so we appreciate that. Thank you, Paul. And maybe we'll see you again for a COVID update, or maybe we won't. We'll just have to see.
We'll pray for the best. Okay.
Thank you.
Thanks, Bill. Okay.
Take care.
Bye-bye.